started whenever you're ready.
Okay, sounds good. Good afternoon, everyone, and thank you for joining us. I'm Julie DeSimone, Program Officer at the New Jersey Healthcare Quality Institute. The Quality Institute is a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everyone. A public health crisis such as the one that we're facing now with COVID-19 tests our strengths and highlights our weaknesses. At the Quality Institute, we're going to continue to have important conversations about today's toughest healthcare issues remotely through webinars, quality briefings, and other valuable resources such as this presentation. We'll get through this together by communicating best practices and learning from each other. We're honored to partner with our member, the American Physical Therapy Association New Jersey chapter, to bring you this presentation. Just a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted on our website later today. All phone lines will be muted for the duration of the program to limit background noise, and you can ask questions at the end of the presentation by typing into the chat box. The topic for today's presentation is the importance of physical therapy during COVID-19. And by the end of this webinar, you will learn patient and staff safety best practices during essential in-hospital PT sessions, how clinicians are working with physical therapists during COVID-19 to reduce risk to patients needing physical therapy, and how to build improved clinician-patient relationships and continuity of PT care during using telehealth. Please be advised that it is not the intent of this program or its speakers to provide clinical or legal advice. We're honored to have Brian Mason and Tom Modica as our expert speakers today. Brian is the current president of the American Physical Therapy Association of New Jersey and director of rehabilitation at one of our newest members, Central State Medical Center. During his stewardship, the New Jersey Physical Therapy Association has received national recognitions for program and membership development. As an active clinician in an acute care setting with over 30 years of experience, Brian has developed innovative treatment paradigms which have resulted in lower lengths of stay and better patient outcomes. The COVID-19 pandemic presents us with unusual short-term and long-term challenges for community health. Tom Modica has been the director of inpatient rehabilitation at our long-standing leadership member, St. Barnabas Medical Center, for over 20 years. He has experience in managing physical therapy, occupational therapy, speech pathology, life team, and newborn hearing services, and has developed programming and clinical pathways for total joint replacement, spine surgery, open heart surgery, ICU care, and burn services. Without further ado, I'd like to turn the presentation over to Tom and Brian, who will discuss the importance of physical therapy during COVID-19.
Thanks very much, Julie. So today we're going to talk a little bit about how COVID-19 is affecting our patients as well as our physical therapy and rehabilitation departments. Therapists have treated, it's nothing new really, therapists have been treating patients with communicable diseases for many, many years, including TB, flu, MRSA, VRE, RSD, and many, many others. The thing that makes it different, I think, about COVID-19 is that we've never had to treat this many patients who have such problems on such a large scale. So really the question becomes, where do we put our resources, as well as how do we help our resources to ensure that all the patients get all of the care they need, as well as making sure that our staff stays safe and able to treat patients on and on. So we had to consider lots of things during the last 2 months or so. And that affected physical therapy, meaning how do I manage our staff? How do we manage the patients? How do we manage the patients' families? How do we manage equipment? All of those things came up, and we had to deal with all those different topics. So over the next hour or so, hopefully Brian and I can give you a little idea of how COVID affected our patients and our rehabilitation departments as well. So you can go next slide, Julie. Great. So first thing we're going to try to talk about a little bit is delivery of physical therapy. And we really needed to modify lots of things since COVID-19 presented so many challenges for us, especially at the outset. Our regular models of doing business in the hospital were really significantly altered, as well as the general physical structure of the hospital. Normally, we have set ICU beds and we have set nursing home, not nursing home, but med-surg beds. Oncology beds, whatever. Things quickly changed very rapidly over the first few weeks of the crisis. So we really needed to think about how we were going to deliver service differently. The first thing we thought about certainly was getting having more consultation time with some of the other healthcare providers, meaning nursing and physicians. We really upped our game in terms of talking to nursing, in terms of how the patients were doing. We were trying to sort of eliminate or reduce those low-value referrals that we all know we get, and so thereby reducing exposure to the staff. So that was one mechanism we started. The next was to really try to minimize minimize exposure of staff on some of these positive COVID patients. And what we did to sort of get to that point was we started a lot of telephoning of patients, of patients who were actually in the hospital. Therapists would actually call those patients if they could answer the phone, and we could do our whole interview section of our evaluation and assessment that we always do. We could do that on the phone. We would limit time in the room. If patients weren't up to doing that, we would certainly call family members and get an idea of whether their family member was ambulatory, non-ambulatory, in a wheelchair, at work before this for 12 hours a day, to get a whole idea of that whole social situation and functional level. This way, when we went in the room, we could stick strictly to performing functional activities and doing the hands-on parts of the evaluation, so it would cut down the time we hopefully had in the room. The next thing was to really try to make sure that the staff was safe. And we had some issues with that initially, and primarily because of what I talked about before, the physical structure of the hospital actually changed. Initially, we had planned for one unit to be a COVID unit, so it would be contained. It would be very easy to manage. But that really went out the window after about 10 days on the amount of patients that showed up that needed admission here in the hospital. So then we went to 2 units, and then we went to 3 units. So initially the idea was all the PPE would be kept on that one unit, and all the ancillary staff could get their PPE and go and see a patient. That just didn't work once we started having lots and lots of units have COVID patients. So we actually opened up our command center, which was a great thing. It became a 24/7 command center. And from that command center in the hospital, we were able to order PPE and get PPE delivered directly to every ancillary department. So we had some little struggles in the beginning getting everybody outfitted, but in the long run, we were able to get all of our staff all the PPE they needed, which was very important for the staff, obviously, as well as to the patients, to make sure that they are protected, and the patients who don't have COVID, that they are protected as well. I have to admit that our corporate supply chain, we're a health system at St. Barnabas, our corporate supply chain did a heck of a job getting lots of PPE into all of the hospitals that are in our system, especially ours as well. So that worked out pretty well in terms of central distribution. Okay, next slide there, Julie. Okay, next part was really staff communication. I thought that was really key, and a key topic that we needed to work on, because it was extremely important. Things were changing so rapidly in the first 3 weeks that new information, new policies, new procedures were coming up almost on an hourly basis, let alone a daily basis. We were lucky in our facility. We have a daily safety briefing. It's usually a very quick in-person, about 30 department heads are there or supervisors, maybe a 10, 12-minute meeting. We started to do that via conference call every day. It turned into a half-hour meeting in the beginning, so it was a little longer, but that really provided us with a lot of information about what was going on in the facility. I was then able to take that information and have a daily huddle with our staff, and I was able to provide them with all those new policies, all those new procedures. We were able to talk about COVID volumes. We were able to talk about where those COVID patients were located. We discussed ventilator use, and we also looked at what the plan was upcoming in terms of where those temporary units would be to house critical care patients. At the end of the day, we would send an email out to all staff, and this was really to keep the information flowing for all of the staff who weren't in attendance that day, so that we would send them that daily huddle information. I would send them any updated things along the line that came up during the day. We would also send a copy of our corporate newsletter, which came out on a daily basis, updating a lot of the critical information in the state of New Jersey as well as in our system. So we would send all of that information out in an email to every staff member every day, so that they were up to speed So when they showed up the next day, they would know exactly what was going on and what had been changed or amended or what was new. So that worked out pretty well for us as well in terms of communication. Okay, Julie, next slide. Next thing was really deployment of staff. So we had lots of things going on here at the hospital, obviously. We had lots of, our volume initially dropped about 50%. And I think that was a major thrust by physicians and others to not expose anyone to the COVID virus patients. That went out the window again pretty quickly when we realized we had so many patients and they had so many needs. So we needed to start seeing patients a little bit more. But we were treating and assessing our usual med-surg patients on a daily basis. But again, volume was not as high, so that offered us some opportunities to help out some other people. ED was overwhelmed, of course. We had tents set up outside, as well as the general ED. So we were donating some staff to the ED for them to help them out, and as well as some of the nursing units, which had high acuity patients. They had increased use of sick time by their staffs who are either quarantined or sick, and just general increased volume for those nursing units. So we sent some staff to there as well and deployed some staff there. Lots of physical therapy departments participated in positioning and proning teams, and we'll talk about those in a minute, what they were doing. But in our facility, we were lucky. We have a very large OR, number of ORs. We have about 25 ORs here at St. Barnabas. So all of that OR staff, we normally do about 70 cases a day. We were down to doing 5 because we eliminated elective surgeries. So we had a lot of staff available to make proning teams out of all that OR staff. So that worked out well for us. So they were able to assist in proning ventilated patients as well as non-ventilated patients. However, our respiratory department was fairly overwhelmed, as you can expect. At one point, we had 100 ventilators running, so they were really stretched. And we felt that we could help out that respiratory department because that's pretty much in our wheelhouse of pulmonary rehab. So we started to get some education for about 25% of our therapists were educated by the respiratory therapy staff. And since we had Governor Murphy's backing of working out of our scope somewhat, we began to do nebulizer treatments for some of their non-COVIDs, chest PT, management of high flows, as well as trying to just do pulmonary rehab with these patients and try pulmonary toilet with them as well. So that worked out pretty well for us. The patients we probably would have seen in the long run anyway. We were able to get in there a lot early by supporting the respiratory department and helping them out and getting in on these patients a little earlier in their length of stay. Okay, next slide. So I talked about proning real quick. And as you can see in some of those pictures, proning's been around for a while. It's been used mostly on those acute respiratory distress patients, the ARDS patients that have been out there for years. There's plenty of literature. The literature supports proning patients with that problem about 12 to 16 hours per day. And there's a couple of pluses and benefits from that. We see some more homogeneous aeration of the lungs. We see a little more posterior lung recruitment during ventilation as well. The drawbacks of proning are putting anyone in that position for 16 hours or 12 hours certainly is going to put stress on some structures. Things like, as you can see the man on the right there, the gentleman on the right, certainly you have to avoid stretching his brachial plexus. We have new pressure points that we never usually see, which mean the ASIS of the pelvis or knees or elbows, spots that usually aren't at risk for pressure. But they are when you prone patients. So we need to obviously as well make sure the patient's positioned correctly in the prone position. Okay, next slide. So let's talk a little bit about some systemic effects of the virus on our patients as well. And just a little aside quickly, about 80% of COVID patients will have minor symptoms or moderate symptoms. About 15% will have symptoms that'll require hospital admission. And about 5% of those, about 5% of the patients will require ICU admission. And things that get you in trouble for ICU admission are pretty much things like shortness of breath greater than 30 breaths a minute, and O2 sats usually less than 90% on oxygen or even on room air to begin with. Those things will either get you on high flow oxygen or make you a ventilated patient. I would also say that part of the problem we know now is that the ACE2 inhibitor, that angiotensin converting enzyme, which changes angiotensin 2 to angiotensin 1s, That is a receptor that is really that is in our lungs, and that's what's letting the COVID virus into our lungs. So we see that directly coming in. We see some down regulation of that receptor as well, meaning that there's less of them because of what's going on, which may sound like a good thing, but it also causes a lot of pulmonary inflammation and increases coagulation of the red blood cells. So some downsides as well. We also see the cytokine storm, which is just that excessive immune response. We see lots of white blood cells coming down to the alveoli, which then start to leak a little bit, and we run into problems with that, because that contributes to alveolar collapse. The virus also has some impact on surfactant. We all know surfactant helps maintain that surface tension of the alveoli. COVID-19 decreases that surfactant, which then decreases the surface tension, which again then leads to alveolar collapse. Once the alveolar collapse in that section of the lung, we can see that part of the lung starting to collapse as well. COVID-19 is also really a lower respiratory tract hypoxemia disease. We don't see a lot of runny noses. We don't see a lot of little sore throats. We see that sometimes in the beginning, but it doesn't progress. It may start out as an initial factor, but it gets much more of a lung disease and an upper respiratory disease. And then we see the ARDS patients, that some of these do turn into ARDS patients where their PaO2s and FiO2 ratios are all out of whack, which then ends up causing lots of ventilation issues and ends up having to put those patients on ventilators most of the time. So that's pretty much the entire respiratory effects of COVID. I would refer you also to that PACER project on YouTube, run by the APTA. That's got some great information. Steve Tepper does one, as well as a bunch of other people. There's some great information on that PACER YouTube videos, and there's lots of them. There's probably 6 or 7 of them. So I certainly recommend you to take a look at those and see what you can glean from that as well. Okay, next slide, Julie. Great. Okay, there's also some effects that we see on the cardiac function as well. We can see what happens is that cytokine storm, again, results in cardiomyocytic dysfunction, and we see cardiac depression in those patients as well. And the COVID virus as well can directly infect the heart, leading to lots of immune cell recruitment, and could actually end up with a myocarditis or myopericarditis as well. We also see the vasculature again being affected, the microvasculature being affected by that ACE2 enzyme we talked about before. And what happens, that might trigger some microvascular dysfunction. And we can see tissue ischemia at that point, which might end up in ventricular dysfunctions or arrhythmias. So lots of cardiac issues can happen as well with these COVID-19 patients. Vascular-wise, we talked about vascular endothelial dysfunction from COVID-19 as the virus binds to those cells. And it ends up damaging those blood vessels, especially in the microcirculation of the small blood vessels. What that ends up in is a lot of coagulopathies. And what we see is lots of little tiny clots going around the body, which eventually we get some platelet aggregation, and those clots come together, and then they're bigger clots. And we see things like DVTs and pulmonary emboli all over the place, and sometimes even stroke. There has been a couple of cases where patients have come in and came in with a stroke, and that was their primary sign of COVID, was the stroke and not these respiratory issues. When tested, it turned out that they were COVID positive, and the stroke was the first sign. We see lots of prolonged prothrombin times as well as high D-dimers in most of these patients that we're seeing. Okay, next slide, Julie. 2 other effects we see of the COVID-19 virus are on the nervous system. Many viruses attack lots of nervous system issues to begin with, so COVID's not any different from any other virus. We've always seen toxic encephalopathies and demyelinating diseases sometimes from viruses, and as I said, COVID is the same. We've seen viral encephalopathies, toxic encephalopathies, and strokes that occur also from COVID-19. So we're seeing lots of things on the nervous system, as well as we know that everybody seems to lose their sense of taste and smell. Those are all nervous system issues as well. That's why those are being affected. One other section is musculoskeletal that's affected by the virus. First of all, disuse atrophy is common with any patient, as we all know, who's on bed rest. These COVID patients are on ventilators sometimes for 2 and 3 weeks. Our normal length of stay, I think, on a ventilator is probably between 2 and 3 days. So 2 to 3 weeks, we're going to see enormous amounts of disuse atrophy and sometimes even critical illness polyneuropathies. But we're seeing, in addition, is because of that hypoxemia, we're seeing a lot less oxygen going to the muscles. And a lot of these COVID patients are showing up with large muscle mass limitations as well. So we need to keep an eye on that, as well as sometimes small muscles are affected in the COVID patients. We're seeing patients in COVID who have also a lot of hand weakness, finger weakness. So it can seem to go either direction with these COVID patients in terms of musculoskeletal dysfunctions. Next slide. Okay, last thing is just mental status. And some of these things are really secondary to COVID, but really primarily because of that prolonged hospitalization and prolonged ICU issues. We all know about ICU psychosis, which may be caused by lots of reasons. Number one is the fact in the ICU, we see a lot of light disturbances. There's no day and night. Things are the same over and over. Patients get disoriented. They get paranoid. They get hypoxic. They get very anxious. And all those things can cause an ICU psychosis, which we did see in some of our COVID patients. The good news is that most times, usually they resolve their ICU psychosis within a couple of days once they're out of the ICU. We also see delirium, and delirium can be lots of reasons: medications, drug toxicities, liver disease, but it's also due to infections. We see it a lot in UTI patients, but now we're seeing it in these COVID patients because of their infection. We're also seeing some delirium in those patients as well. And then sundowning, which we always see in our geriatric dementia population, but we're seeing a little more common now. Again, more confusion in the evenings and nights. We see some memory loss in these patients, and it's primarily due to these long hospitalizations where people are getting confused because there's a lack of stimulation and a lack of day-night ability to differentiate between the two. So I think that is it for now for my section. I'm going to turn this over to Brian, who will talk a little bit about some of the treatment, as well as some of the long-term projections we have for physical therapy and these COVID patients. So Brian, it's all yours.
Thanks a lot, Tom. We shared everything you went through on a smaller scale. We're a smaller hospital. The motto of the department became subject to change because it would change from 8 a.m. to noon to 5 p.m. And staff just did a phenomenal job adapting to that. And I'm sure you share this, Tom. We know more about supply side metrics than we ever cared to learn. And I can understand that the difficulty that they went through. What is the goal? Our goal of physical therapy is essentially to get the person back as functional as quickly as possible. Initially, because of some of the challenges with PPEs, we were limited to access to the patients, but that quickly changed, and we did catch up. That was a universal challenge. I can't imagine. We went through for instance, like 90 and 95 of masks in February a week, and then you go up to 900. It's just unbelievable. They did catch up. So the biggest intervention is you want to get the mobility back to the patient as quickly as possible. These are multifactorial sick patients, and some of them decompensated so quickly. Just even bedside sitting was a huge issue for a lot of people. Big challenge. I know, Tom, we touched on the ICU psychosis, and I think it's kind of a perfect storm. You have a person who goes into isolation, sometimes for weeks on end, and the only people they see are in head-to-toe PPEs. So I think that is, on a good day, that's disorienting. So if we take a look at the next slide, increasing functional strength, I think that I'll stay on this one for a bit, because chest PT and these people didn't have a lot of secretions. We did have our team up there doing prone lying. Did a great job. It's been a number of years when I did proning, and when I did it, my PPE was a pair of gloves. So a lot of times it would be 10 minutes to get in the room, 10 minutes to get out. You need 3 or 4 people. You need the RT, you need the nurse, you need 1 or 2 other people, depending on the size of the patient. We had good results with that, and our critical care team did a phenomenal job. A lot of good cooperation between RTs, the nursing staff who here was phenomenal. We were in the same position as you. We had 1 unit, then 2 units, and 3 units, and then making up units, turning a short stay unit into a med surge floor within a day. So they did a great job with that. So as far as the next slide on increasing functional strength, if we can move to that next slide, please, Julie. Okay. There are a lot of tools that we have in our toolbox. I think the most important thing is get that person weight bearing, get them doing as much as they can. On our side in physical therapy, 3 days in bed, you lose neural tone. Any disease, the fuel for that disease is immobility and loss of function. There is nothing that makes better acutely, nothing. So getting the patients up and moving them as quickly as possible. This is again, multifactorial patients who presented with significant problems, vastly ranging. So usually our goal was to get them weight bearing. Traditionally in a acute care hospital, what you like to say is get them up, get them out as safely as possible, because we want people out of the hospital as quickly as possible. Our next slide about mobility status is, I think that that's the biggest thing. Even getting a patient, I love the picture here. I remember the good old days when you used to walk into a hallway without full PPEs and no masks before COVID. That's not going to happen anymore. Getting the patient even bedside sitting, as you know, is huge for us. And if you could do postural correction, just getting them do some deep breaths. We were fortunate we were able to pair a lot of times the PT with the OT for some of the functional needs that they go over. When you're in a room, a COVID room with a partner, a lot of times you need those 4 hands, and that's time consuming. It's certainly not, it presents a huge challenge for people. Ambulating, I mean, we were very happy to get them bed to chair. I think a lot of therapists know some people can tolerate about 5 minutes and that's it, but it's a starting place. That's where we need to start. So our next slide, if we can go. Exercise programs probably ties in better what we did with telehealth. Physical therapists are really, really good at managing patients' anxiety. We have challenges when it comes to our own anxiety, but we do really good with that. And the other thing that physical therapists are masters of are diffusing that fear of physical activity. This is across all the realms we see. People develop those fears. They're afraid they're going to hurt. They're afraid they can't do it. And this is where physical therapy really comes in vastly important to get people back to where they were. We all know that people will adapt to their new normal very, very quickly. And now you have people who have been incredibly sick, and they will decline rapidly. So if we take a look at our next slide. Recovery, some of them are using oxygen. We know that their respiratory function can be compromised. I know in RED, I'm sure it seems everyone, it's incredibly impressive when someone who passes the eyeball test, doesn't look, that they have a lot of comorbidities, comes in and they're talking and their pulse ox is in the 60s and 70s. So this was, we never saw that before. Getting people back to where they were is always our biggest challenge. What strategy you use on the acute care is generally mobilization. You want to get them up. You want to do what you can as quickly as possible. Let the patient do as much as they can. Not easy to do in full PPEs. My hats off to those nurses or anyone who can breathe through an N95 for 12 hours. I don't know how they do it. Our staff upstairs did a phenomenal job, but even they were exhausted after a few treatments. Treatments are very intense with these populations, a lot of times due to the PPEs you're wearing. Our next slide on strength deficits. This is the biggest challenge for therapy is people lose whatever function they have. As I mentioned, loss of function, immobility are the fuel that fires disease. It just makes it worse. So getting these people up quickly as possible are very, very important, whatever we can do. The muscular weakness due to nerve injuries, we're going to see that down the road. With positioning different patients for a prolonged period of time. Oftentimes they come up with these bizarre neuropathies, whether it be foot drop, brachial plexus. So we do need to be conscious of that. We're starting to see this as they come into outpatient. They're presenting with different type of challenges. So our next slide. Yeah, activities of daily living, just function. We all know that function is a key indicator of how healthy you are, at least for physical therapy. It influences your health greatly. We want to get people back to optimal health and function as soon as possible. Tough population, because oftentimes you did not have access to what their functional history was, because like most hospitals, no visitors once this started. Getting hold of family members is challenging at times. Some of the patients were not intubated, so obviously they can't give you much of a history. So this has been a constant challenge for us. We were fortunate. Again, we had OTs upstairs. It helped a lot. A lot of co-treatments, a lot of great cooperation with the nursing staff. Our nursing staff here did a fantastic job. I know that other hospitals, I saw nurses who I hadn't seen in 5 years who came out of retirement to help out. One of my favorite lines was from a nurse who said, "I was born to be a nurse and I will die being a nurse." So, okay, future. Our next slide. Staying home. This is a huge challenge. We have a population out there for 2 months has essentially decreased their functional activity dramatically. So for every acute care hospital therapist out there, if you have access to a falls report from your ED, you're going to see an increase. I will guarantee you. The rest of 2020, next couple months and into the fall, you're going to see these falls go up because people haven't been doing things, okay? Generally, I know even from my personal experience, binging Netflix is not really a high motor skill. So we need to get people back out there, and I think this is a great opportunity for physical therapy to move into a little bit of a different realm. Everything from lack of stimuli that people get, social interaction. We know these things function have incredible impact on people's well-being and health. So that is something we certainly want to do. People adapt to a new normal relatively quickly. And you figure 3 to 6 weeks, you can make some fairly significant changes. We've had people who've been ventilated for 3 to 6 weeks on and off, and you know that their changes are dramatic. But our general population that is out there has really, really changed their level of function. So that's going to be an interesting challenge for us moving forward. So what is the future of physical therapy? Well, if I had a crystal ball on our next slide, I would kind of tell you what it is. It's going to change. One thing I'm very cognizant of, and I think any therapists on here have to be, when the polio epidemic came on, Elizabeth Kenny was out there, changed the face of physical therapy. World War I, World War II, when these vets came home, changed the face of physical therapy. I think particularly in our area, we need to take on a more advocate role and getting out there for the patients. Now, granted, I am hospital-based, and the days of us just sitting in the clinic, I think are limited. I think we need to be out there acting as healthcare advocates for our populations. How can we keep them from getting into the emergency room? I know a couple of years back, our CEO here asked me, how are you going to get these falls down from the emergency rooms? We have too many fragility fractures coming in. And we've been working on that, but obviously that's going to increase dramatically. This is going to be a challenge for us. I think telehealth was helpful, again, for those reasons. I think it will have a role going on. Telehealth has been challenging, like any rehab visit, because not only are you dealing with the patient, you're dealing with multi-payer sources. They all do things differently. They were all somewhat caught by surprise by this. They responded the best they can. Some of us, if you follow what CMS did, initially they came out with saying that physical therapy and occupational therapy could be done. But the challenge with that is they didn't say it could be done by a physical or occupational therapist. So we had to take a look at that, and we did work through them. I know with the Department of Education in New Jersey, they've been very, very cooperative with the APTA of NJ regarding expanding telehealth for pediatrics and for particularly for PT and for occupational therapy. So those those are the challenges where we exist now. I do think that going forward, there's going to be great opportunity for physical therapy, maintaining our community's functional health. And I much prefer to work with people when they don't have a lot of challenges. I know one of the questions that comes up all the time, and our census for elective surgery certainly went down, as every hospital did. Emergency room visits certainly went down. If I tore my rotator cuff 3 weeks ago and I can't have surgery, that's not elective surgery. So we're going to see a lot of people who postponed different type of surgeries, not by choice, and that can present some challenges we're not used to seeing. I believe that's the end of the slides. And Julie, I thought you wanted to open up for questions.
Yep, great. Thank you both for all of that great information. And so before we answer questions from the chat box, I'm going to ask you a couple of questions that I have first. So those of you participating, if you have a question, you can type it into the chat box now, and we'll get to as many as we can in the time allotted. So this question is for Brian. There have been many articles on people foregoing appointments, as you were just talking about, because of fear of COVID-19 exposure, and have the follow-up procedures changed for those recently released from the hospital to make sure they're continuing PT that they need at home as an outpatient?
Yeah, that's a great question, because if you have a blue and white sign with a big H on the road, people are scared to death of you, and rightfully so. Again, everything went down in the hospital. Med-surg cases, ED visits, so people were having, had strokes, weren't coming in on a timely manner. People who needed acute care weren't coming in on a timely manner because they were very, very scared. And I did touch on a lot of people. If you tear your Achilles tendon and it can't be repaired for 6 weeks, you're a very different rehab patient than what we would normally see. So those, even though they call them elective, they're kind of urgent surgeries. So there's been a lot of things that have been kicked down the road. Where that settles, it's going to be a challenge. But one thing I'm really confident of working with the therapy professionals here and all my other colleagues is they're going to adapt, and they'll adapt very well to it. People in healthcare think on their feet very well. They put the patient first. So that's probably been the most impressive thing I've seen. But that's a great question.
Great, thank you. And this question is for Tom. What is your advice to a person who has never been to a physical therapist but needs one now, but because of COVID-19 is reluctant to go?
Well, I think there's a couple of options now, more than we had before because of telehealth, but we'll start off with many physical therapy places, first of all, have been open throughout the pandemic, only they've changed things the way they've operated. Hospitals are still seeing some outpatients, especially ones who are post-operative in the beginning when we first started, as well as I'm sure private practices were doing the same thing. But now we sort of add in that whole telehealth component. So a couple of things as advice to some of those patients would be, number one, I think you should vet a physical facility, a physical therapy facility, the same way you would have before. I would go online, check some reviews. I would get recommendations from people who have received physical therapy or not at a facility. That's number one. Number two is then once you've whittled that down to a couple that geography-wise are close to you, because you may still need to go there. I would then vet those places in terms of a phone call, see what some of their procedures are in terms of cleaning procedures, amount of patients being seen in the facility, meaning that most places have gone to about 1 patient per hour just so that they can manage social distancing, obviously, or will they provide masks for patients and staff? Those kind of simple questions that we see out there every day now with every type of business are still good questions to ask. The next question would be, can they be managed through telehealth or not? And that, again, needs to be a phone call to that facility explaining their disability and their problem and letting them know, can this be something that we can manage over the phone via telehealth, or do I need to come in there? And it may be a hybrid. It could be a hybrid of going in the first time, receiving an examination, being instructed in some things, some exercises, and then some follow-up visits via telehealth, or it may require manual therapy or things that must be hands-on. So that's up to the therapist to figure that part out, obviously. But that's some of the ways I think I would go through the process. If I was a patient who was a little uncertain, I would sort of vet those facilities, see how they're being managed at this point, and then make some phone calls and decide whether this can be done via telehealth or via in-person visits.
Great, thanks. Those are some great things for people to think about. And so this last question is for both of you. So looking ahead after we resume to our new normal, do you see any practices that you've developed during COVID-19 that you'll continue because they increase patient safety and access?
I'll start off real quick. The work we did with our respiratory department turned out to be, I think, very fruitful because it really gave us some inroads to these pulmonary type patients that I think we would get later on down the line. So I think the lesson for us is to really start to collaborate a little more closely with our pulmonology groups and our respiratory department so that we can work a little more closely with these ARDS patients as well as any other patients who have such severe respiratory complications and get to them as soon as possible and start working with these patients much earlier on than I think we were. We were always in the ICU, but I think early mobility has taken on a bigger focus now even. And I think we should try to get to these patients as soon as possible. And even though they may be very, very low level, I'd still like to see us work a little more on these patients hand in hand with respiratory. That'd be my goal.
Yeah, I would have to second that, and I think one of the changes I noticed was that even though typically these are very acutely ill patients, most of the floor staff, the physicians recognize that the sooner you get some mobility in there, the better off they would do. The ultimate goal of every healthcare practitioner is what's best for the patients. And they're all physicians and nurses were all result oriented. So they saw the good results, and it was incredibly labor intensive. Our inpatient staff did a phenomenal job with this, juggling multiple issues, collaborating with both the RTs and nursing a little bit more, a lot more was useful. One of the dirty secrets of medicine is oftentimes we live in our own little silo. And that I think has changed a lot because those silos were pretty much shattered.
Great. Thank you both. And I'm going to turn it back over to Tyler for some of the participant questions.
Great. Thanks, Julie. So if anybody has questions, please type them into the chat box or the Q&A box at this point. We'll try to get to as many as we can. First up, we have a question about home visitation. I think we have some physical therapists that may be doing work in people's homes. Are there any precautionary measures that you can suggest for those physical therapists that are doing work in patients' homes to keep themselves safe?
I guess my first suggestion is make sure you have enough PPE. You kind of have to assume that even though they may have come up negative at some point, they still certainly they are possibly contagious at some point, or one of their family members are contagious at some point. So I would say PPE is still a must because we're just not certain because of the testing, the lack of testing, and the lack of us knowing exactly who is positive, who is negative, who is contagious, who isn't contagious. PPE has got to be a plus right there for those therapists, as well as in terms of on the clinical side. I would really look at the pulmonary part of these patients with a real keen eye, much more than we used to look at these patients in home health. I think taking their SATs frequently is important. I think getting them on home programs of prone lying are very important because that still seems to work very well in oxygenating these guys. When you walk in and they're at 90% or 91, and you prone lie them even for 10 minutes, I see them going up to 95 and 96. So I would certainly look at the pulmonary aspect of these home care patients but in addition to the mobility aspect that we're so used to looking at.
Yeah, I think having a portable pulse ox with you is a weapon that you certainly want to have. You can't just eyeball the patients. A lot of them, their saturation level can be surprisingly low. We know a lot of adults don't like to get on their stomach, but certainly I think that's a great adjunctive. We are a hands-on profession, so you're going to have to Purell, hand hygiene, desperately hand hygiene, and mask if you can get it. And all healthcare practitioners seem to make this mistake when they get comfortable or tired. They contaminate themselves with the mask. They handle it. So it's going to be slower, that's for sure.
Thank you. Great advice. A couple other questions coming in. Somebody wanted some more information about how New Jersey hospitals are prepared to work with their patients after discharge through telemedicine. If you could just elaborate on that. I know we touched on it a little bit.
Well, what I would suggest they do is go to the APTA NJ's website for its it's also open to non-members, those few who have not seen the light yet. And there's a lot of information out there because telehealth is going to change again after this is over. So one insurance carrier will have a different policy from another insurance carrier, from another insurance carrier. You will get emails saying X insurance carrier is doing it this way. Yes, that's true, but that's in Delaware. So it is really difficult. And this is the thing I think that always frustrates the physical therapist so much. It's the clinical part's the easy part compared to all this other nonsense.
Yeah, let me just echo what Brian said. I think, I mean, the perfect example of what he just said is CMS itself. Over the last 3 weeks, they've changed direction 3 times. So it doesn't get any worse than that. So staying up to date with your state insurers as well as CMS, and there's plenty of information out there, either CMS webinars or general webinars. You need to stay informed, and even that's not good enough because it's almost changing in real time as we speak sometimes. 2 weeks ago or 10 days ago, hospitals couldn't bill telehealth visits because of a form, the HCFA 1500 versus the UB04. Last Friday, that changed again, and now they fixed it. So it's literally changing as we speak sometimes. So staying abreast of things is super important for everyone.
Thank you. And we at the Quality Institute have done a number of webinars on telehealth and have a telehealth resource guide. So I'll share that with everybody in our email follow-up as well as the APTA&J website. So a question maybe not necessarily related to physical therapy, but as the state starts to return to some activities and starts to open back up, what are your thoughts coming from the hospital perspective? Do you think that we're going at a good pace, I guess, to open things back up? Or your hospital situations, do you think it needs to be slower?
I'll go first on that. I'm a little frightened, I'll be honest with you. We had a discussion just before we started this webinar today, Brian and I, and maybe Tyler, I think it was, is we had 30 admissions today of COVID patients as opposed to only 5 discharges. Those numbers are clearly turned around from what it was just 2 weeks ago or 10 days ago, where we were discharging 30 and admitting 5. Some of the relaxation of all these restrictions, it may be a little too soon. I'm not sure if we'll see a big spike, but we're going to certainly see not as much of a significant decline as we were seeing, and it may even go up a little bit because it seems to be headed that way. We still are at about 100 COVIDs in our hospital, and that's only dropped less than 10% in a week, which is our lowest drop yet. So that's just my feeling.
Yeah. You know, that is a huge challenge because sometimes we run into one size fits all. If you go to parts of New Jersey that they have not been impacted, like Central Jersey and North Jersey, particularly where Tom is. So it is a challenge. I think at the minimum, absolute minimum, people should be wearing masks. They should be doing hand hygiene, and they should be distancing reasonably so. It's a little bit of a damned if you do, damned if you don't, but there are going to be consequences to this.
Absolutely. And one more question that we got in. Others, please enter them now. Are many of your patients being instructed to prone lie even post-hospital discharge?
Yes, absolutely. I actually do some home care patients, and I've had them prone lie, and they do very well. As I said, patients will pop up 3, 4, 5 points on their O2 sats just from 10 or 15 minutes of prone lie. I encourage them to, obviously there's criteria for that. If the patient is very significantly elderly, you want to take some precautions there. But a lot of our patients are in their 50s and 60s and 70s, and they can prone lie without any problem at all. And I pretty much recommend it several times a day. I ask them to prone lie for 10 or 15 minutes. Seems to be helping them anecdotally. So I would say yes.
Yeah, we you know, that a lot of adults don't want to get on the floor, so we eliminate that and say somewhere in your house you have a bed. We know you do. And then because their cervical range of motion may be limited, just do the pillow trick under the chest and accommodate. We've seen the same results too. We also always want the patient to have a mechanism to treat themselves. That's very important.
Great, thank you. And not seeing any other questions come in right now, I'm just going to share some last minute last minute follow-ups with everybody. Just wanted to let everybody know that we do have another telehealth webinar coming up next week. We are partnering with AARP and one of our board members, Mary Campagnolo. She's a family physician and geriatrician with Virtua, and she's going to be talking about some of the challenges that older adults may face in accessing telehealth and how we can overcome some of those issues. So it should be a great webinar, another one in our series. I wanted to share also a link to all of our resources that we've put out on COVID-19. So I mentioned we've got a telemedicine guide. We just put out a prescription assistance guide for folks. So a lot of really great material there, along with the recordings from each of our webinars in the series. So about later today, probably this afternoon, this webinar recording will be there as well. And then Brian and Tom, if it's okay with you, we'll post your slides as a PDF as well. And then just waiting to see if any folks had any other questions. I'm just getting in some really nice thank yous. It was a wonderful presentation. I'll echo that, and want to say thank you to Julie for moderating. Thank you to Brian and Tom. Thank you to APTA and Jay, as well as both member organizations, Central State and RWJ Barnabas, for lending us your talents today. So appreciate it, and hope everybody has a great day, and look forward to our follow-up email.
Thank you.
Thanks so much.
Thanks for having us. Appreciate it.
Thank you.
Bye-bye.